This is our People podcast, telling the stories behind South Tyneside and Sunderland NHS Foundation Trust.
Hello and welcome to Our People podcast. I'm Fiona Thompson, Media and PR Manager at South Tyneside and Sunderland NHS Foundation Trust. Today's episode is a special live recording from our Patient Safety and Safeguarding Conference 2025, and it's all centred around Martha's Rule. Named after 13-year-old Martha Mills, who tragically died of sepsis after her family's concerns weren't acted upon, Martha's Rule is about making sure patients and families are heard. It's about preventing avoidable harm by recognising deterioration early and responding swiftly. You'll hear from Dr. Phillip O'Donnell, who is one of our emergency consultants, and Lisa Hobbs, who is Martha's Rule project lead and also a critical care outreach team lead here at STSFT, as they share why this initiative is so vital. We're also joined by a panel of 4 passionate staff members who'll speak about what Martha's Rule looks like in practice, followed by a live audience Q&A session. So stay with us as we explore how this powerful initiative is helping put safety, compassion and listening at the heart of care.
Too many patients die having been unheard, and this is where Martha's Rule started. So what is Martha's Rule? Martha's Rule has 3 components. The first is patient wellbeing or wellness question. So these are questions that we ask of the patient, or in the case of a patient who is unable to answer due to delirium, cognitive impairment or other matters, then utilising those that know the patient best in order to understand how they are compared with how they were. It also has a route for staff who are not being heard. We know, and there are too many examples of where members of the team know that a patient is not well and know that something needs to be done and make representation of that, but that nothing is done. So Martha's Rule provides a route for those circumstances in which staff who have tried through normal routes to escalate, to be able to escalate for a second opinion. The third element, importantly, is for patients, families and carers to be able to have that same route of escalation when they have tried to tell the healthcare team but feel that they are not being heard. It's part of a wider approach, and it is part of the NHS England patient safety strategy. What we're seeking to do is prevent deterioration. We know that patients who are in our inpatient areas are there because they are not well. We should be able to prevent many of them from deteriorating. Where we can't prevent it, we need to identify it early, escalate, and provide an appropriate response. So Martha's Rule comes with some underpinning principles that are founded on the principle of it being proactive, not waiting for people to deteriorate and need resuscitation, but instead identifying early, as soon as we can, that they are deteriorating and taking action before they get to the point at which they need resuscitation or escalation to a critical care environment. So the underlying principles are to listen to and seek to engage with patients and their families because they know themselves best. Even those patients that we know well, we don't know them as well as they know themselves or their relatives know them. We should be asking a routine question at regular intervals. The recommendation that we give is 3 times per day, should be the times that we ask our patient wellness question, to get a complete picture of the patient's condition. This is about empowering everybody that is involved with the care of patients to be able to improve recognition and action once we've recognised it in relation to deterioration. And importantly, recognising that a unique contribution that patients themselves and their families and carers can provide. I'm going to hand over to Lisa so she can tell you a little more.
Thanks, Phillip. I'm just going to talk about the patient wellness question This is the first step of Martha's Rule and is fundamental in enabling us to listen to patients. At South Tyneside and Sunderland Foundation Trust, we now have the Martha's Rule assessment. This is the patient wellness question. It's added to everyone's work list on admission, and it's now mandatory for all inpatients. Prior to the rollout in August, the assessment had been piloted on 4 wards, C33, B26, Surgical Centre inpatients and Ward 6. It consists of 2 questions: how are you feeling now, and how is this compared to the last time you were asked? With response options being good, bad, okay, and better, worse, and the same. These answers are given a value which generate an outcome. Is the responsibility of the nurse looking after the patient, the registered nurse looking after the patient, to act on any response that's given. This allows a structured approach to ensure worries and concerns are captured, documented, and seen to be acted upon. The evidence from the first 6 months pilot suggests improvements in some key performance indicators, with some qualitative evidence from patients that conversations have taken place and that they have been listened to. And survey results also show that junior staff have felt more empowered to escalate than previously. The most significant improvement being the reduction in referrals to the critical care outreach team for patients scoring a News 2 of 7 or higher. This has reduced by almost 75% in the last 6 months, suggesting that deterioration is being recognised earlier, with fewer patients in these wards triggering. Culture can play a massive part in the failure to identify, escalate and respond to deterioration in a timely manner. Often members of staff, patients and relatives feel if they do speak up that this will have a negative impact. In March this year, I spent an afternoon talking to patients and relatives about Martha's Rule, just explaining the process and what it was about. 3/4 of these that I spoke to had a story to share, and I imagine everyone in this room also has a story to share, whether that had been a patient, a relative or a staff member, where they felt that they weren't being listened to or unable to raise concerns. I was really, really taken aback at how a massive amount of people that had a story. One lady thought that if she spoke up about her pain, that she would be badly thought of and it would have a negative impact on her care on the ward. And one lady who tried to escalate her mother, who she knew was deteriorating, felt that because she didn't have the right words and she didn't know the medical terms, that she was ignored and that she couldn't express herself properly, but the staff on the ward hadn't actually listened properly to what she was saying. I'm going to hand over to Phil again.
Excellent. Thank you, Lisa. So our call to action is about culture. Through embedding Martha's Rule, we have the opportunity to explicitly address culture. Now, culture is about how we do things around here, and it's all of us that contribute to that. So we need to make sure that we are paying attention and hearing the voices of our patients and our colleagues. If you're not being heard, there is a route through Martha's Rule to seek that second opinion and to involve people who we expect will be able to challenge and ensure that your voice is heard appropriately. We need to build in equity checks. Do we treat people well? All people, or just some? To embed behavioural and social emotional discussions through safety huddles, debriefing and handover, making it normal for us to talk to one another about whether we're being heard and whether we have any concerns. Being able to disagree respectfully without being disengaged or disrespected. Patient and family observations matter. They know the patient best, and therefore we must make them part of our team. We need to empower them to raise concerns. Now we can do that through engaging with them, by asking questions in ways that they will understand in order to use the language that they have to share their concerns with us. Anyone can request a review and must not be penalised for asking for that review. And we need all to think about how we behave in relation to this as part of that team, because together we create the culture.
So luckily this morning we've managed to have some of the staff who've been taking part in the pilot of Martha's Role come along to support. And I just thought it would be better to hear it from staff who've been using it for a little while rather than ourselves, on what impact it's had on them and on their working ways. So we have Carol, Shannon, Laura and Emily, and we wanted to sort of start by discussing the importance of listening to patients and their family and whether that adds value. Carol.
So I've been a nurse a long time, and I've found over the years it is really important to listen to families, because they're the ones that know their relatives best. And I know when the ward's busy and you've got relatives constantly coming to the nurse's station wanting to speak to you, sometimes you think, we've got too much to do, but it is important. And it's best to start off, if it's possible, when you're admitting your patient. If there's relatives there, they can tell you, especially if the patient's elderly, this is not their normal. They've come into hospital because of this problem, but they're normally independent and chatty. The patient might not be that. And then you've got an assessment that we can follow during the course of their stay. Using Martha's Rule, you can assess that during the course of the day to see if there's any changes. I recently had a lady whose family were very, very concerned, and she'd had a procedure done and she was being NG fed and persistently vomited. The family's raised concerns. The lady herself said she didn't feel very well. But we felt that, this was the only treatment that was going to be offered to this lady. However, over the course of the weekend, because of persistently monitoring this lady, it was acted upon and she was taken to theatre, had surgery, recovered, and she went home. So I did feel in that case the family were listened to, and there was a positive outcome for this patient, and that's all we can wish for our patients at the end of the day.
Thanks, Carol. So what you're saying is, in that situation, the family were the ones who picked up the deterioration, and you felt that was listened to, and there was a good outcome?
The family did feel at first that they weren't being listened to, and we did ask the medical staff several times to come back, and things were explained to them. And the family thought that they needed further explanation, they needed further investigations. And like I say, they didn't feel as though they were being listened to, but during the course of the weekend and persistence, then they were eventually listened to, and CT scans were arranged and the lady was treated. And the family did feel as though they'd had a good positive outcome because they were listened to eventually. Yeah.
Do you feel that what you were saying there is obviously through experience that you pushed for that to happen?
I think with experience you can recognise deterioration often before it's evident in the numbers, in the news scores. If you know your patient, if the family know their relative, if you liaise together, then yes, it can be recognised. And I think Martha's Rule is particularly good for the junior nurses who haven't yet got that experience to recognise these things and don't feel as though they're empowered enough to keep persistently asking for help, which sometimes us older nurses don't really mind being persistent.
Okay. So I was going to talk to Emily about that, about how junior nurses are using Martha's Rule.
Yeah, so I think just to add on from your point, I've seen the junior staff, because we've got quite a few new junior staff on the ward, and I've seen how much it's empowered them to have the confidence to raise their concerns. Because I think when you first start, it's so overwhelming. It's such a task-driven job, and I remember from when I first started, You're trying to analyse these numbers, you're trying to ensure that your escalation is appropriate, and I think this just gives junior staff that confidence to think, I do need to escalate this to a doctor, and it just adds the patient's and the family's outlook onto the situation. I think as well, I think it gives that empowerment to the junior staff, and I think it's something I would have really valued 4 years ago when I first started.
Has anybody had any incidents where they felt that they weren't listened to and had to use Martha's rule?
So I had an incident with a patient who wasn't necessarily scoring high on the news, but just something wasn't quite right. I think a lot of us know what I mean when I say that. A lot of family concerns as well. So I did speak to the doctor about it at the time, and unfortunately the doctor didn't really listen to the concerns that I had. So Martha's rule was in place, and that was something that empowered me to raise those concerns. It gave me the confidence to do so, despite the fact that the doctor didn't seem too interested as well. The staff as well made me feel very supported, and I felt as though I was ensuring the safety of the patient, and it also reduced the risk of the patient deteriorating.
Yeah, thanks. I was going to move on to Shannon, because I think Shannon's had an experience as being a relative as well, and she was going to talk about that experience.
I'm Shannon. At the moment I've got a relative in hospital on a ward, and I went in 4 nights ago and she had a spike of temperature, so I told the nurse. The nurse said, okay, I'll get the doctor to see her, give her a paracetamol. Rang up, said she was comfortable, went in the next night. I went in, she was lying in the bed and she was saying, oh, I was Shannon, I feel ill. I feel absolutely ill. And I know, she's my mum actually, I know me mum, and she was really off. So when I got the nurse back, done her temperature, 38.7, got the doctor to see her, done all the blood tests, white cell count was up, started on IV antibiotics, her potassium was low, so we started on an IV drip. So to me, as a relative, Martha's rule sort of empowered me to go to the nurse and say, oh, I'm not. Because when you're a nurse, it's a different scenario. When you're on the other side, it's just totally different. So I felt the nurse, she was only a young nurse as well, I think it empowered her to challenge the doctor to do what you had to do, like blood cultures and things. So I just think Martha's rule is a really, really good thing for all nurses, I think. And relatives, mostly relatives, because like Carol was saying and the girls were saying, you know your relative better than anybody. And I knew my mum was ill. She was, the nurse was saying, oh, she's okay, her numbers are okay, her muse is okay. I said, but she's not right. She's not right. So she followed up on that, and I got a drip up with potassium in, she had blood cultures done, she was started on IV antibiotics. And I'm thinking, if I had let that go as a relative, she probably would end up septic. But she's on the improvement now, so yeah. I'm really passionate about it, you know. I just think it's a good thing that's coming, and relatives should be heard. They should be heard. You know, like Carol says, when you're busy and you think, oh, here's the relative again, and then but you act on it. And as mature nurses, we can see a patient deteriorating, or like we say, the numbers they're not scoring. So.
And that's a bit of nursing intuition.
Yes,
as well.
And when the younger nurses are in that role for a number of years, they'll be exactly the same. Exactly the same.
Yeah. Thanks, Shannon. I just want to open up to any questions from the audience for the panel members or myself or Phil.
I've got one concern really about it's a marvellous scheme to set up. My concern is that the phone is not manned, and I just wanted to ask, which at the end of the pilot scheme, I'm hoping that will be funded for someone to be answering that phone all the time, because we all know patients can go off very, very quickly.
Currently, the phone isn't, well, it's not manned 24/7, as in it is manned a lot of the time, but if obviously we're out seeing a patient, then that's left. The answer phone triggers an email to all members of the team. So currently, if you rang and left a message, it would trigger to everybody that somebody has left a message. So even if one person was busy out, somebody will still know that someone's left a message. So although it's not as rapid as what we would like it to be, it is as good as we can get at the moment. And I think, I'm not sure, we did try a mobile phone, so we tried that first, the mobile phone, but with the hospital signals being like that we did miss a call, because the call didn't even go through the answer phone because of the signals in the hospital. So it was decided to go to a lined phone. I'm hearing that there might be talk in a few years' time of us going away from the bleep system and into the deck phones, which would be a lot easier, because then that number could go straight to us. But until then, I think this is the safest way, is to make sure that a message is left and that we can act on it in as most timely manner as we can.
So, excellent work. I'd just like to single out the team. Actually, we are leading the way with this. One of the key concerns when we started to do this was, are we going to increase the workload for our nursing staff? So I'd like to hear from the panel if you've actually experienced that. That was a key risk with the executive team, but when we put the questions in, I think it's 3 times a day, are we going to increase the workload of our nursing staff?
So that's has doing the assessment 3 times a day increased your workload?
Definitely not.
When we do our daily assessments, we're at the patient's bedside and we ask certain questions 3 times a day. We'll have to do VIP charts 3 times a day. We do stool charts 3 times a day. So you're asking the patients these questions anyway. So adding this is no greater workload because you're at the patient bedside anyway. So it's no harder job just to say to the patients, how are you feeling? Do you feel any better, any worse? So I would say no, from a personal point of view.
On the flip side of that, Lisa, trying to get a business case through is like arm wrestling. So one of the other questions asked, I think Phillip might remember this, is are we going to increase the workload of our critical care outreach team?
Yes, so what we found so far is that the number of calls on the 6-month pilot from those pilot wards didn't decrease or increase, they pretty much stayed the same, but the nature of the calls changed. So the calls weren't because there were news of 7 or they were acutely really unwell. It was because there was a concern, and so the calls have remained the same number, but the reason for referral is different. And also there was the time taken on the calls has gone up slightly, so we are taking more time on those calls, but the number of calls has pretty much remained static.
And the reason I ask these questions, if you remember Sir Jim Mackey's, we're on a journey, we'll never have a destination. So I think with Martha's rule as well, we are never going to have a destination. So you mentioned how can we quickly contact staff. So we're exploring handheld systems, our tech is changing. So I think as things come through in the future, we'll actually just strengthen Martha's rule from that aspect as well.
Did anybody else have any questions? There is a hand, a couple of hands. Have we got time, Catherine? We've got 1 minute. So while I'm walking to look at hands, which I can't see anymore, where's the hand? Thank you. It's just about language. So what we sometimes hear when people are escalating is, such and such has a news of 6. That's a number. It doesn't mean anything to me. If you say to me, Mrs. Smith is unwell and I'm worried about her, please come, you'll get a better response because I'm a human being and that triggers me better than news of 6. So don't say it's a Martha's Rule escalation. Tell us what the concern is. If you escalate into the medical team, share the human story.
Hello, thank you. From what I understood, that by using matters from what I have seen, by using matters rule, healthcare profession can, make sure that their concerns are being heard and acted upon most time when you raise this concern, first of all, you can say you want to decide with yourself that you have a concern to raise. Sometimes we became scared of raising that concern. And when you have finally decided upon yourself to raise the concern, that's the thing that made you to raise the concern still has not any positive, when you have reported, there's no positive impact that made towards what the concern that you have raised. So I just want to know, in this case, what can we do as registered nurse? Thank you.
Shall I say this one?
Yes.
So if you ring through, you're ringing that, so if you've got a concern, your first route of contact is to the normal escalation route. So to the clinical team that are looking after the patient, if you've got a concern, we don't want staff to be ringing the Martha's Rule number the first time, okay? Because we need to do our normal business. So contact the team. But if you do that, you speak to the doctor on the ward or you bleep them and you get a response that isn't coming to see the patient in a timely fashion and making a review, then what Martha's Rule allows you to do is go to a different team. So that is to the critical care outreach team by ringing that number. If you don't get a person at the end of the phone, leave a message and they will get back to you. You need to be clear about who you are and where you are and what it's about so that they know what it is they're ringing you back for. But then they will be the people that are coming. So the practitioners from a nursing background who are coming to see the patient to support you. Okay? And that hopefully will be empowering to then engage with the medical team. Is that helpful? I think we had one other question. Have I got time, Catherine?
At the back somewhere. Oh.
Hiya, thank you so much. Totally support Martha's Rule. I am one of the consultant gynecologists. I'm just interested to know the experiences of the ward nurses who are using this Martha's Rule. So when you feel you need to use this, do you need to talk to the ward team that you are needing to take this route, or how is this the relation between the nurses and the ward doctors? Have you felt dismissive, or just want to know when you're using this route?
So I think that's, have you found any conflict between when you've, with your ward teams, if you've had to use Martha's Rule?
I mean, on surgical, we've never had any conflict. When we've reported a high immune or the patient's unwell and the doctor. My mate wants to speak here. And using Martha's Rule, just escalate it. If you feel your patient is deteriorating, just escalate it to a doctor. Martha's Rule, you're looking out for your patient, so you need to tell somebody, and if that doesn't get sorted, you tell somebody else. So you keep going until you find somebody that's going to come and see your patient. Because you know as a nurse, you've got a responsibility for your patient, you're an advocate. So Martha's Rule, if you think your patient's unwell, even if they're not scoring, you get in touch with the doctor. Don't ever be scared to get in touch with the doctor. You look after your patient.
Well done, Shannon. I think pretty much out of time, is that right?
We are. So the final kind of wrap-up is a request that you make sure that you understand how Martha's Rule works. Hopefully we've explained that for you sufficiently, but we've got a stand at the back, so come and talk to us if you've got any questions. If after today you think of any questions, then feel free to get in touch with either Lisa or myself via trust emails. And thank you very much for your attention.
Thank you for tuning in to this special episode of Our People podcast. If you'd like to learn more about Martha's Rule and how it's being used across our trust, visit our website www.scsft.nhs.uk, and if you click in the services, you'll find the Martha's Rule section there.
Thanks for joining us for this episode of Our People podcast. We hope you enjoyed it and check out our other stories. Hit subscribe to keep up to date with the latest and catch up with what we've been up to on our Twitter, Facebook and Instagram pages. Just search for our name.